Hi, this is Moby Parsons, and I'm an orthopedic surgeon practicing at the Knee Hip Shoulder Center in Portsmouth, New Hampshire. Our practice is dedicated to rapid recovery after knee, hip, and shoulder replacement, and we have been pioneers in same-day surgery using these rapid recovery techniques. You can see our contact information here, as well as our website address. Today I'm going to present a comprehensive overview of the Conformis patient-specific custom total knee, including the rationale, the design, and the results of this. This is a knee that I've used extensively over the past 4 years and have been very happy with the results, which I think really speak for themselves, and we will review this. Total knee replacement is generally a very successful operation, and it has now been around for at least 4 to 5 decades. The patient profile has really changed over the years, and we now see more people in their 40s and 50s who present with end-stage arthritis. And we also see a lot more people in their 70s and 80s who remain very engaged in competitive and high-demand physical activities. So as patients continue to test the limits of what these medical devices can do, what they really want is performance, and performance includes good range of motion, stability, fit that feels normal, a high level of function, a durable joint that allows them unrestricted activity, and something that lasts for a long period of time. What we as surgeons want is the ability to do this predictably and have a high rate of patient satisfaction. We want outcomes that are reproducible so that we can tell our patients in a high percentage of cases we can achieve good to excellent results, and we want to be able to do this in a manner that presents few complications to the patients. If we look at the current results of conventional knee replacement, up to 20% of patients are not satisfied with the results. And this is simply unacceptable given today's technology. If you look at other operations such as hip replacement, the patient satisfaction rate is much higher than this. And given the demands that people have in terms of their active lifestyle, we need to do better than to have 20% of our patients not fully satisfied. These are series reporting on the outcomes of total knee replacement, again depicting in graph form the high rate of patient dissatisfaction ranging from 11 all the way up to 39%. And you have to realize that these series are reported by people who come from academic medical centers who tend to be experts in their field. So even in the hands of very experienced and master total knee surgeons, there is a high percentage of unsatisfied patients. If you look at success at 5 years and you look at various different endpoints, what this graph shows is that if you include cases that go on to revision, patients that have continued postoperative pain, and low satisfaction scores at 5 years, there are 70% of patients satisfied, meaning 30% of patients are dissatisfied at the 5-year mark. If you compare age-matched controls between people with total knees and people without total knees, you can see according to this graph that those without a total knee perform much better in everyday activities, including activities of daily living, but also leisure time physical activities and competitive activities. So the black bars show that a much higher percentage of age-matched controls are able to participate at a higher level, and those with conventional total knee replacements have lower performance scores across the board. If you look at what the drivers of patient dissatisfaction are, these are fairly well understood given that knee replacements have been around for a long time. Obviously, early implant failure requiring revision is a cause of this. Fortunately, this is not too common, but happens in 1 to 2% of cases. This can occur because of problems of leg alignment, rapid wear of the materials, poor implant engineering, and also sometimes secondary to problems of implant placement such as instability. Residual pain can occur again in 10 to 15% of cases which have clinically significant residual pain, and this may be related to improper component fit or malposition of the implants when they are placed at the time of surgery. And finally, poor function, limited range of motion, stiffness, instability, or problems with joint position sense. Patients who are unsatisfied with their knee replacement report that their knee does not feel normal, more than twice the rate of patients who are satisfied with their total knee. If we look at the top 10 reasons for early failure of knee replacement, 5 of these reasons are secondary to either mechanical, technical, or implant-related issues. And these include malposition or malrotation of the implant, meaning we don't put it in properly. This also includes what's called varus tibial component position, which means placing the tibial component so that it is at an improper angle relative to the long axis of the tibial bone. Failure to correct the mechanical axis of the entire lower extremity. Problems of how the kneecap tracks in the groove of the femoral component. And failure to balance the soft tissues, which can lead either to stiffness or instability. All of these things can be controlled both by implant engineering as well as surgical technique. And these are opportunities for where we as orthopedic surgeons can do better to raise the bar on patient satisfaction after total knee replacement. If you look at how conventional knee replacements are designed, they come in an array of sizes to match variability in patient anatomy. These sizes are based on thousands of measurements taken from cadaver specimens. And as you can see from this graph, there's a wide range of sizes as indicated by these small black points. This is called a scatter plot. When you develop a scatter plot, you can then draw a trend line as indicated by the blue line, and then create average points across that line that correspond to the sizes of the prosthesis. You can see on this graph there are several different implants that are graphed, and you can see even within different implant types the variability in the size relative to the average trend line through that cluster of data points. And you can see that several of those black points are far away from the implant sizes of these different systems, meaning that if you are a patient who has a knee size that may be out here off the trend line, one of these sizes here of the implant is not going to fit your anatomy very well. This is another graphical representation looking at various different measurements of both the femur and the tibia in the medial to lateral and anterior posterior planes. And you can see that conventional implants do not address the variability in femur and tibia sizes across the population very well at all. And some of these implants, you can see, again, are far away from the cluster of data points. Furthermore, each implant company differs in how its generic sizes address this anatomic variability. And this is not something that can be determined preoperatively, so that we as surgeons cannot measure the bone using any easy technique and then determine which implant company is going to have a component that best fits that patient's anatomy. Surgeons tend to pick a single company that they use for all comers, and if that particular implant system does not have a size or a shape that fits the patient well, then compromises need to be made at the time of surgery to make that implant fit. It's similar to having a shoe that does not come in half sizes and therefore either has to be slightly too big or slightly too small, and this can lead to problems that cause residual pain. For conventional implant systems, again, they come in an array of sizes on both the femoral side and the tibial side. And you can see here that oftentimes these need to be interchanged to size match for the patient. The surgeon may have to then determine at the time of surgery which implant size will fit the patient correctly. Sometimes the femur and the tibia do not correspond, so that you may use a size 4 femur and a size 3 tibia, in which case the plastic liner may not match very well. And again, These may have implications for the performance of the implant, both on a day-to-day basis, but also in terms of its overall longevity. Poor implant sizing can be due to overhang of the component, which means the metal of the implant overhangs the cut surface of the bone, as shown in this picture here. And it can also be because of improper coverage, where the bone actually sticks out from the prosthesis. In traditional implant systems, up to 57% of patients have overhang of one component of at least 3 millimeters in some area of the total knee. And it's been determined that 27% of residual pain in a total knee is secondary to overhang of the femoral component. So this is a significant issue with generically sized implants. And again, this has been published in the Journal of Bone and Joint Surgery, demonstrating that in men, at least 40% of people can have 3 millimeters of overhang, and in women that number can be as high as 68%. If you look at the curvature of the femoral component, there's no consensus about this issue either. The curvature varies according to implant design. So each implant maps out this curvature differently in terms of its radius. And again, this can affect the tension in the soft tissues around the knee and its stability throughout the range of motion. Studies have shown that standard traditional off-the-shelf total knee replacement geometry does alter the kinematics, or the way a total knee moves inside the body. These different videos here show conventional off-the-shelf implants, the Zimmer Next Gen, the Biomet Vanguard, and the Stryker Triathlon knee. And in a normal knee, as the femur goes from extension into flexion, the femur should roll back on the tibia. As you can see from these videos, when the knee goes into flexion, there is often erratic, or in some cases paradoxical motion, where, for instance, here in the Zimmer knee, the femur actually paradoxically slides forward instead of backwards. Here with the Biomet Vanguard, there is some posterior rollback, but again, it occurs fairly erratically. And in the Stryker knee, there's also paradoxical anterior slide as opposed to posterior rollback. This kind of paradoxical motion can put stress on the soft tissues in the anterior part of the knee, causing residual pain, particularly with activities such as getting out of a chair, going up and down stairs, or walking up and down hills. Tibial coverage and rotation is also a major issue with conventional implant designs that tend to have this fairly symmetrical shape that you can see here. And in order to align the tibial component with the patellar tendon, or where the kneecap tracks in the groove of the femur, it is often the case that there will be areas of bone that are uncovered and other areas where the implant may overhang the bone, such as here, because the shape of this implant is not designed to match coverage and rotation. If we were to take this implant and rotate it so that we could get better bone coverage, the problem is that we have now improperly rotated it relative to the axis of the kneecap, and so that would cause maltracking of the kneecap that could be a residual source of pain. And it's quite common that this occurs in up to 30% of cases where there is plus or minus 5 degrees of improper tibial rotation. And here again is a picture demonstrating how this can be a factor, where if we choose the right size implant for optimal coverage of the bone, we have to internally rotate it relative to the foot here. And if we want to pick an implant that we can better rotate relative to the foot, we get improper coverage. So we're forced to make compromises between coverage and rotation. Studies have shown that patients with internal rotation of the tibial component are 5 times more likely to experience anterior knee pain after a total knee, and have complications associated with the joint between the patella or the kneecap and the femur. Excessive internal rotation of the tibial component in particular explains about half of all residual pain in total knees. So again, a very significant issue and one that can be better addressed by implant design and surgical technique. This also has been published in the medical literature showing that up to 5% of all total knee replacements have been implanted with significant errors in internal rotation of the tibia. So if you ask why we need personalized solutions, number one is that everybody's anatomy is slightly different and there is no one size fits all in total knee replacement. Knees are like snowflakes. Each one is different in its own way. And furthermore, arthritis differs amongst patients. So these x-rays here demonstrate 3 different types of arthritis. This one on the left shows predominantly kneecap arthritis. In the middle here, this is arthritis predominantly involving the inner part of the joint between the femur and the tibia, causing a bowing deformity of the alignment of the lower extremity. And these on the right side show predominant involvement of the outside joint between the femur and the tibia, also called valgus arthritis, causing more of a knock-knee deformity. Each one of these patterns of arthritis requires specific methods of correcting alignment and soft tissue balance, and they're all different in the way that we as surgeons need to approach them. So again, a one-size-fits-all approach is not correct either for patients' anatomy or their arthritic wear pattern. And herein lies the concept that there is really one implant that should be specific for each individual patient based on their native anatomy. And this concept really was started about a decade ago by a radiologist who realized that we could get very detailed information on patients' anatomy from high-resolution CAT scans. And these CAT scans could then be used to develop a custom patient-specific knee replacement, and they could also use sophisticated CAD and CAM or computer-aided design software to determine exactly where that implant should be placed to restore the geometry of the knee as well as its kinematics, or the way that knee moves in the body. The design rationale is to have a patient-specific or customized fit, a customized patient-specific implant positioning to restore all of the relationships, to restore the mechanical axis of the entire lower extremity from the hip all the way down to the ankle bone, to design an implant that preserves bone and does not remove a lot of the native bone, which may be better long-term, to create a design that is optimized to reduce wear so that these will be durable and last for a long period of time, and to do this in a manner that is efficient for the operating room staff so that this case can be done again reliably and reproducibly. This starts with a CAT scan that gets cuts through the hip joint, detailed cuts through the knee joint, and cuts through the center of the ankle joint. And by getting cuts all the way down the lower extremity, the engineers can then create an implant that restores the overall alignment. So if you see all the way over on the right here, we want to see a line through the center of the hip that passes through the center of the knee and passes through the center of the ankle, and that is proper alignment of the lower extremity. And all of this can be calculated out with a CT scan and designed into the implant. The shape of the implant itself respects the patient's geometry. So each knee has 3 curves along what are called the condyles of the femur, and these are called the J curves. As we talked about previously, studies have shown that standard total knee geometry alters the kinematics because it does not replicate these J curves. And as we stated previously, there's no consensus about which generic J curve is best for all patients. Conformist takes an entirely different approach where by matching the J curve of the patient, it gives the patient the J curve that is appropriate based on their anatomy and how the soft tissues work around that particular joint. So it provides a more natural fit, a more natural feel, and better stability. These curves can be corrected for deformity and then used as a basis for the implant design. In addition, the CT scan allows determination of the appropriate flexion axis of the knee. So each knee has a flexion extension axis, and this is slightly different than what's called the transepicondylar axis, which is how most standard total knee replacements are referenced. So if we rely on the transepicondylar axis, which we can see at the time of surgery, we may have a tendency to malrotate the femoral prosthesis. And because of the sophistication of the imaging technology, Conformis can actually calculate the appropriate flexion extension axis and design the implant in a way that replicates this. In addition to this, the Conformis implant can replicate what is called the condylar offset. So this has to do with a concept called the joint line, where the distance between the surface of the bone here and the insertion of the ligaments which occur at these areas called the epicondyles is a fixed relationship. If we don't restore that fixed relationship, both in the frontal plane as well as with the knee inflection here, we will have improper tension in the soft tissues, which can cause either stiffness or instability. Again, these can be calculated by the CT scan and the implant designed to correct the patient's condylar geometry to normal. Again, this is difficult to do with a standard off-the-shelf implant. And if we don't get the joint line right, again, this has also been shown to alter knee kinematics and lead to something called mid-flexion instability, where when the knee comes into the mid-range of flexion, the tension in the ligaments is too loose, and those knees will be unstable and painful. So by replicating condylar geometry and condylar offset, we can approach more normal kinematics and address one of the causes of pain. Again, if we look at the concept of rollback, the Conformis iTotal knee replacement, because it replicates that condylar geometry, comes much closer to replicating normal knee kinematics than does a conventional implant here. So again, the iTotal is in the purple line here, nearly replicates the normal rollback of a native knee, and here you can see the difference here when looking at femoral rollback. There's also an issue of asymmetry that we see in normal knees, where oftentimes the joint line posteriorly is more elevated on the lateral side here. Conventional implants do not take this into place. So the Conformis creates a personalized fit that helps take all these compromises out by replicating condylar geometry and offset, creating a perfect fit. This is important because there are certain areas that are very prone to overhang because of inaccurate condylar geometry. One of the most common ones is where the popliteus tendon courses over the back outer part of the femoral condyle, and this is a common area where implants may have overhang and that popliteus tendon can rub, causing pain. Conformis is able to create some relief in the implant, as you can see here, to limit that risk, as well as create an implant that better fits the bone. So in short, if we can replicate the geometry of the femoral condyles and the native J curve, we can more closely mimic the natural shape of the knee, and this plays an important role in the way the knee bends and extends. By restoring the natural shape of the knee, rather than replacing it with generic and standardized geometry, the knee should feel closer to a normal knee, and this is really what we are trying to achieve with our total knee replacements, is the feeling of a normal joint. If we go back and look at these videos that we saw before, again, we can see the Conformis knees are on the top here, the off-the-shelf knees are on the bottom, and we can see how well the Conformis knee replicates that rollback of the femoral component as shown here. You can see there's a nice rollback pattern as the knee comes into flexion versus some of these other implants that have erratic or paradoxical motion. And again, that is going to lead to less stress on the soft tissues. This has been proven in studies. So Dr. Komistek is a very prominent biomechanics researcher out in Colorado who has extensively looked at the performance of knee implants in actual patients where they have a sophisticated imaging array that allows them to take live x-rays of patients doing everyday activities and studying things like lateral rollback of the femoral component, rotation of the component, and condylar liftoff, which is where the femur and the tibial components come away from each other in flexion. And what we see again is that 44% of off-the-shelf knees demonstrate paradoxical anterior slide, which is not normal, whereas 91% of conformist patient-specific implants replicated normal knee function. So that raises the bar quite a bit. The other important thing is this issue of condylar liftoff, which is as frequent as 56% in conventional off-the-shelf implants. And what this means is the femur and the tibial components actually lift away from each other, and this can be a cause of soft tissue irritation. And in the conformist knee, that condylar liftoff was 0%. So I think that's a huge improvement over our traditional replacements. The conformist knee also uses a 6-cut design, which maximizes bone preservation. So I won't go through this graph in detail, but the gist of it is if you look down here at the bottom, for all these different cuts, when you compare the conformist to conventional implants, there's up to 2 millimeters to 3 millimeters of less bone that's resected in various different places during the total knee. And I think the more of a patient's native anatomy that we can preserve, the better for long term. And the conformist shows up to 28% volumetric bone preservation. If you look at the tibial side, again, the CAT scan can create a very detailed map, not only of the shape of the tibial surface, but also of the rotation relative to the patella and how it will track in the femoral implant. They can then create an implant profile which is matched to the rim of bone here with slight relief in the back here. And this allows a little bit of intraoperative adjustment without any implant overhang, but it maximizes coverage of the cut surface, which is good for stability of the implant. So again, a patient-specific shape and fit. The other thing Conformist does, as you may recall from previously, because there is a variation in the offset on the inside and the outside, they create custom polyethylene inserts that are a little bit thicker on the outside to replicate the natural condylar geometry and still create a high contact area for the implant, which minimizes wear. So this has a high congruency, which again decreases the stress on the plastic and improves the long-term wear and stability of the knee, and also helps restore proper alignment. Conventional knee replacements have a purely rectangular piece of plastic here, and that does not replicate that condylar offset as we saw previously. This plastic insert, or the polyethylene bearing insert, also has a very conforming surface as measured, and this allows for what's called low contact stress during the range of motion. If you compare this to other competitors on the market, which you can see from this graph, is that Conformist maintains this low contact stress throughout the entire range of motion. And that, in theory, should be very good for long-term performance and wear. So the total surface area of contact remains more consistent. You can see some of these other ones have limited surface area of contact, which is going to generate higher forces in the plastic implant. There's various different ways that they have engineered wear optimization into the components, specifically in the kneecap articulation. This is the plastic button that gets placed on the back of the kneecap. This is also highly conforming, so there's low contact stress. The lateral ridge has been lowered to help decompress the soft tissues here. The trochlear groove, which is the groove where the kneecap glides against the femoral implant, has been extended to help deep knee flexion. And again, there is a very wide geometry here for the condylar design of the femoral component to allow low contact stress. Again, the delivery model, very efficient. Patient starts off by getting a CAT scan. The implant is ordered with an order form that goes off to the company where they generate a three-dimensional model, and they have very sophisticated algorithms that can then take this model and design a patient-specific implant. They also design these cutting jigs, which are also patient-specific and are designed to fit the bone perfectly, so that during the operation, the surgeon can apply these jigs to the bone, and this will ensure that the implant is placed exactly where it should be to replicate the joint line, the condylar offset, and the flexion extension axis. And all of this comes in a single package, so all the cutting blocks in the implant come in one box, which reduces the amount of inventory in the operating room and the number of kits that need to be opened, which can correspondingly reduce the surgical time and things like blood loss and infection. This shows what's inside the kit. So each one of these, again, is a patient-specific cutting block that we use during the operation to set the position of the implant. They give us trial implants that we can use before we put the real one in to make sure that we like the size and orientation, and then finally the real implant as shown here. This is a video showing the image to implant process here. We'll allow this to play for a
second. The Conformis process starts with a patient CT scan through the hip, through the affected knee and ankle. The proprietary iFit software converts the two-dimensional CT data into a three-dimensional model that replicates that patient's unique anatomical bone geometry. In the 3D environment, iFit recreates the patient's natural J-curves, corrected for deformity. From the 3D model of the patient's knee, iFit software builds the femoral and tibial implants to match the unique size and shape of each knee, which are designed to address common causes of patient dissatisfaction, including pain and unnatural feel. That same 3D model is also used to design patient-specific instrumentation for each step of the surgery, allowing for an efficient and simplified surgical technique. Conformis has pioneered additive manufacturing and 3D printing technology for producing single-use patient-specific iJigs. Instead of reusable instruments that require cleaning and re-sterilization, iJig positioning guides come pre-sterilized and are used on only one patient. iFit design and manufacturing technology enables mass customization, a term foreign to the orthopedic industry. Unlike any knee replacement available today, Conformis customized implants and iJig instruments are delivered pre-sterilized in a single box before surgery, greatly reducing hospital costs associated with implant storage and instrument sterilization. Simply put, iFit technology and just-in-time delivery model put Conformis in a class of its own with unparalleled speed of innovation.
The other thing that's very nice is Conformis provides the surgeon with what is called an iView, which is a customized surgical plan for each case. And this tells us exactly how much bone we're going to remove for each one of the 6 cuts that we're going to make on the femur, as well as where that femoral component should be positioned relative to the design of the implant. And they'll give us this for the tibia as well, in addition to telling us the different size plastic inserts that we will have available. Again, it tells us here exactly how much bone we will be removing from each area around the tibia. And this allows us to come into the operating room, and if there's specific changes that we may want to take, such as resecting a little bit more bone off the cut surface of the tibia to help restore range of motion, we'll know that in advance of the case. This is a typical post-operative image of a conformist knee, and essentially what this shows is a very well-aligned knee replacement with perfect coverage of the tibia here, perfect coverage of the femur with no overhang, excellent restoration of the mechanical alignment of the lower extremity, excellent position of the implants relative to the bone, and just a seamless fit of that implant relative to the patient's native knee. And again, because of the accuracy of this technology and the imaging, this is what we can achieve in virtually all of our conformist knees. And when we use conventional systems that have very archaic and conventional jigs, achieving this kind of consistency can be very, very difficult. We now have clinical data that really reinforces all of our anecdotal experience with this, showing increased patient satisfaction with patient-specific knees, improved kinematics or knee motion that feels more natural, as we have shown, and overall better function. This is a study looking at hospital metrics for patients reporting outcomes for customized total knees and conventional total knees. And essentially what you see here in this graph, the conformist knees are in orange, showing average time in days to achieve level walking, stairs, and flexion to 90 degrees, showing that with the conformist knees, all of these milestones were achieved significantly faster than with traditional total knees. The overall OR time was also 16 minutes faster on average. There were fewer soft tissue releases needed for the conformist knee relative to the off-the-shelf knee. The overall length of stay in the hospital was shorter, likely because of these other factors, and the overall recovery, again, was faster for the conformist knees. Here's another graph looking at patient outcomes. The KOOS score is the knee osteoarthritis outcome score. And again, what you see is higher level of patient satisfaction and higher KOOS scores for the iTotal conformist patient-specific knee compared to a traditional off-the-shelf knee. Again, statistically significant differences. Another multi-center analysis of patient outcome and function with customized individually made knees versus off-the-shelf knees showed that patients were more likely to have a good to excellent outcome with an odds ratio of 1.7 times greater for the custom-made total knees versus off-the-shelf, and 2.6 times more likely to have a poor objective knee society score for an off-the-shelf implant compared to a conformist knee.
You watch this. This is your job.
This is one of our patients about 4 hours after he had his right knee replaced. And I think what this demonstrates is that Conformis is an integral part of a rapid recovery program. So with better patient education, patient preparation, advanced pain management, improved anesthesia, and patient-specific implants, you can get your patients out of the hospital and into the comfort of their home within hours of their surgery. And this patient is actually walking out of the hospital to go home shortly after having a Conformis total knee replacement. Conformis also makes partial knee replacements, and these are also the only patient-specific customized partial knee replacements on the market. Currently, depending on the center, about 20 to 40% of all total knees are done in patients who could potentially have been candidates for a partial knee. Advantages of the partial knee is that the ACL and PCL ligaments are both preserved, and it preserves more bone and cartilage. It's slightly less invasive, smaller incision, and potentially a faster recovery. But again, not everybody is a candidate for this. There are very specific criteria that patients have to meet to be an appropriate candidate for a partial knee replacement. Again, this is the only truly patient-specific unicompartmental knee replacement on the market, and this is what it looks like in the picture on the right-hand side of the screen here. It can be used for arthritis either on the medial or the lateral side between the tibia and the femur, and again provides a customized fit to the knee that is designed to mimic the natural shape and retain more natural function. And again, because of the minimally invasive technique and the custom instruments, it can be done in a less traumatic way with fewer bone cuts to preserve more natural knee structure. If you compare the conformist knee to the Makoplasty, which has also become quite popular because of direct-to-consumer marketing, I think one of the key things to realize is that the Makoplasty does not use a customized patient-specific knee. It still uses an off-the-shelf knee system. And in fact, for the total knee, the Makoplasty uses a system that was designed in 2005. So I would argue that it's a 13-year-old total knee system, and many updates have been made since that period of time. In order to perform a Makoplasty, additional holes have to be drilled into the bone so that trackers can be placed for the robot to reference the patient's anatomy. So I would argue that that is not a minimally invasive surgery. In fact, you could argue that it is more invasive than a conventional partial or full knee replacement, and therefore the surgery takes longer. I'd say to summarize what we've seen from this talk is that there are still too many patients with traditional off-the-shelf knee replacements who remain dissatisfied because of stiffness, pain, or limited function. Clinical studies have supported what I've seen in my practice, which is with the conformist knee, I see happier patients, more consistent results, better patient satisfaction, improved knee motion, a more natural feel, and better function. Again, I've been using this knee for about 4 years now and continue to do so on a regular basis. I don't think it's absolutely necessary in every single patient. It does take approximately 6 to 8 weeks for the implant to be made, and occasionally I see patients that don't want to wait that long, and I think they can do well with other systems. But I do like all of the principles that Conformis has designed into this implant, and I think it helps me be a better surgeon and provide more value-added solutions for my patients that have end-stage knee arthritis. I'd like to thank you for listening to this talk on the conformist knee. You can find more information about this implant at the Conformis website, as well as our website listed there at the bottom.